I'm Dr. Tyson Morostiga.
And I'm Dr. Derek Moore, and we're your Sports Quacks.
All right, welcome back to all of our Sports Quacks. So today we're going to jump into talking about adjusting the cervical spine or adjusting the neck. And kind of the risks and benefits. Are there risks? I mean, here's the thing. Adjusting the neck is safe. It's safe for 99% of patients. But I think when it comes down to doing it, it's using clinical judgment. And then it's also understanding how the patient's going to respond to it, right? So, Derek, I want to jump to you quick, and I know I could have given a long intro to this, but here's the thing: if you're a chiropractor, you've heard this over and over again. We preach this, and people, they talk about it in school until, their eyes are blue. Or is that the right thing? I don't know. The face blue in the face. Yeah, that didn't feel right. Yeah,
eyes are blue.
Eyes are blue.
That's a problem too. But I'm just not too sure what kind of problem.
What's the disease where it's their eyes turn blue? The bones don't.
You're talking about
bones don't grow.
It's the fragile baby
bone disease. Let me look it up here because it's going to drive me nuts. I'm going to look it up exactly. Fragile baby bone disease.
There you go.
I'm going to look it up just like that. And it's
osteogenesis
imperfecta. So you got blue eyes. Sorry. Yeah. But here's the thing. We're told over and over again until people are blue in the face that cervical adjustments are safe. And I feel like the way that they go about explaining it is done to cover their butts or to fight off against MDs who apparently all hate us, which they don't. So, Derek, let me jump to you. And I just want to talk, if a patient comes in and they have neck problems, what's the likelihood that you're adjusting them, and what are red flags to prevent you from adjusting?
Generally, I would probably put an adjustment in more than likely after the exam, 100, 95, 90.
Yeah.
And now when I say adjusting too, I'm including mobilizations of the spine.
Yep.
So I'm not just saying HVLA. So I will talk to my patients about their previous experiences with chiros and if they have any issues with spinal adjustments, and then I'll walk them through it. And then if they have any issues with it, I have a pretty set way of explaining it. It's like, okay, so we could do the adjustment or we could do a mobilization. Adjustment takes probably 2 to 3 seconds. Mobilization takes 15 to 20 seconds. Mobilization, I'm just going to bounce at the end field and really just kind of allow for the joint to slowly groove that pattern that we're trying to move it in. And I just let the patient decide at that. But generally, when it comes to the assessment in the history, that's what's going to tell you whether or not you're adjusting your patient. And if you're not taking that proper history and assessment, then that's where you're going to make the mistakes. So red flags, terrible headaches that they never experienced before, numbness, tingling, consistently radiating down into the arm, pain radiating down into the arm, nausea, dizziness. If you notice they have some droopiness to half of their face, I mean, these are, I think, in any clinical history taking, are some pretty easy things to hit on before you ever get your hand on the person. So just touching upon the things that you learned in chiro school is the biggest safety net you'll ever have.
Nothing, but let me say this. Nothing, if you're a student, there is not a single thing that is going to prepare you for the patient that comes in and goes, I had vascular surgery 3 weeks ago. I'm jacked up, but I need my neck adjusted.
Oh, right.
Nothing is going to prepare you for what to say to that aggressive patient who wants that done. And I've had that done. Let me ask you this, Derek, have you ever adjusted someone and then afterwards felt like, yeah, that probably might not have been the best clinical move.
decision. Um, not nec- I had one patient who did have a stent put in,
And then like a
and
carotid, like a carot, like
yep,
an okay,
yep, and he was just like, "Hey, listen, I get adjusted all the time. It's fine." I'm like, "Okay." So I I looked through the notes, and I checked the notes, and everybody says that they've adjusted his neck, and I'm like, "Okay, that I'll take that." And then I asked them all the questions still, just like, "Hey, any major headaches, any issues with blurred vision?" I hit on all of those and cleared that. So I was like, "All right, you, let's do it."
hmm
And it's obviously a lighter adjustment. I understand too that he really just wants the cavitation,
yeah,
so we just achieved the cavitation. Honestly, patients don't understand that cavitations don't mean anything. So what was funny was I just ended up adjusting his lower cervical spine and
avoiding any
avoiding.
risk.
I just followed the entire scar, and I'm just like, I'm just not going to be anywhere near it,
Yep.
and got it to cavitate very easily, and person was happy, didn't have any issues afterwards, but I was still a little bit worried, I'm
Yeah.
like, he's going to walk out of this room and he's just going to
Drop.
drop dead, and I'm going to be the last person that he's seen, and it's over for me.
Yeah.
But other than that, that's probably the only time I've been a little bit queasy when it comes to
When it
it.
comes to it, yeah. And I've been there before too, and I'm sorry I put you on the spot. I could have said
Oh,
that. I could have said for initially that yeah, I've been there, um, because you do worry. Because oftentimes you get patients who come in with similar symptoms of stroke, of different issues. But here's the thing: like, if you go through the proper clinical process of evaluating, managing, and figuring out what's going on, you can rule those things out. Recently, I had here in Arizona, there was a chiropractor who a patient had a stroke after seeing a chiropractor, and it popped up on Facebook on a group that I'm in. Go
oh,
figure, right?
yep.
And not all the information was there, and I haven't seen anything in the news about it since. So I've been looking for it, but nothing's ever come to it.
Okay.
So um, the thing is I think when it comes to adjusting the cervical spine, patients are at a very, very low risk. It's not likely that you're going to cause a stroke. It is actually, you're not going to cause it. I'm just going to step out on a limb. You will not cause it. But if a patient is having a stroke, they're still going to have a stroke after you adjust them. Doesn't mean that you're going to cause them to throw anymore, but guess what? They're still going to finish that stroke, or they're still going to finish throwing that clot, whether you touched it or not. That thing's broke free. It's going somewhere, and it's going to cut off blood flow.
Mm.
So I think what's really vital is understanding the setup to the adjustments. And let's get away from the risk. Let's talk about like just comfort, right? One of the biggest risks with cervical adjustments is that they are just really uncomfortable.
Right.
And they can be. But I think that's when it comes to the technique is so important in understanding what joint does what. Like, are you forcing rotation in the lower cervical spine? Well, guess what? Those things don't rotate. So, well, they don't rotate much. But why are you doing that? Why are you doing hard rotary adjustments?
Right.
Right? So let's talk about that. Like, if you are assessing, like, say like somebody has an upper cervical issue versus a lower cervical issue, does that alter your setup?
Generally, I don't let it um, too much. It's more so um, as I'm applying the. So I'll do kind of more of a motion pal, bounce through different end fields.
Mhm.
And the biggest thing that I'm trying to assess is, okay, can I place a nice firm contact in this area without this patient jumping off the table? Because if I can create a solid a solid fulcrum to for my contact, it doesn't. I'm not so attached to the cavitation that I'm thinking, all right, this is going to cavitate right here. I'm a little bit biased where I say it's going to cavitate right there, but I I just believe that it's more so in my own bias palpation. This joint just isn't moving the way I want it to move, and then I'll do the adjustment in that area with some type of directional force to create this, once again, the biased opinion of motion in that
In
joint.
that joint. Yeah.
Yeah, I hate, I really know, and I'm sorry, folks, I know I don't need to continue to preface everything that we do because we're all, for the most part, we're all clinicians listening to this, or we're all just trying to understand this together. But I just don't want to come off as a manipulation kind of zealot, you know. But at the end of the day, manipulation is our bread and butter.
Mm-hmm.
And if you're not good at manipulation, I'm sorry, you're not going to be the best chiropractor. And that's only because, for the most part, manipulation is what people are going to come to you for.
Yeah.
And you might have the diagnosis down, you might have the active care down, but if you don't know how to properly manipulate the spine, then more than likely you're not going to be able to become successful enough with the patients who want manipulation to create the following that you need for more people to come into your clinic. I'm telling you, I've done it where I've done manipulation, and then for the first 2-3 visits, and then never manipulated again. And it was mostly the more times they came in, the more times I got to educate them on what's really going to improve their condition, and then they didn't care whether or not they were manipulated. Sometimes they just came in and were just like, hey, yeah, I just want to get adjusted and I'm good. That's not a problem either. Get them adjusted. Ask them, are they doing their exercises? Ask them, are they doing their stretches? And that's fine. I think that's fine. I don't think you're doing any harm with that. But if you're a young student getting about to get out of clinic, and you have a hard time adjusting people, and especially a hard time with the cervical spine where you just don't feel comfortable, I implore you to not, and try not to bash other techniques, but I implore you not to just say, well, I don't care, I'm just going to do activator. I implore you not to do that. Just learn how to properly manipulate, and then if you want to do activator as your primary go-to, I'm fine with that. But understand that there's less research in what you're doing with activator than there is with spinal manipulation.
Okay, so let's talk about that activator. Do you use the activator? Do you use the activator at all?
I haven't used activator since our VA residency.
Oh man, that's a long time. I like that.
I just don't, because anytime that I could use activator, I could be doing a mobilization instead.
Yeah, I like that.
So I'd rather just do the active mobilization. And honestly, I'm not going to say I didn't lose patients over it, because I probably did. Mm-hmm. Patients like certain techniques, and I've told patients from the beginning where they during our intake forms, patients tell us they see chiros, they got activator done, and I would tell them, hey, we don't do that, but I do know an activator doc. If you're interested, we'll continue with care. But if not, and you want activator done, I can easily refer you out to them. And a nice interprofessional referral is cool to me, you know? If they want to do activator, cool, do activator. You want AK, fine, that's fine. You want Reiki and stones and all of that, go ahead. I don't do any of that. I'm not going to pretend to do any of that, but I know somebody who will. And if that's what you want, as long as you're not going to die from it, go ahead, do it.
I'm okay with referring you out.
I'm okay with referring out.
So a lot of times when it comes to anyone who's had any type of neck trauma, chiropractors get deathly afraid, right? So like if you have a cervical fusion, like the chiropractors are deathly afraid to adjust or manipulate joints. Have you noticed that?
Right, absolutely.
So I get patients come in here with not multiple fusions, but I have multiple patients with fusions is the way I want to say it. And they'll come in and they'll be like, oh yeah, they'll bring their x-rays. I always want to see it because I want to know, like, I need to see that before I touch it. But they'll show you, okay, 4 and 5 are locked up, but they've lost motion, they've lost rotation in their cervical spine. Well, most rotation happens in the upper vertebrae. So, well, technically that fusion isn't going to shouldn't restrict their rotation all that much. So I'm not afraid to adjust the spine with the segments that aren't fused. That doesn't bother me. And let me tell you, the reason why is because guess what? That fusion is a whole lot stronger than your hands are. It's
Right.
not going anywhere. But the thing is you have to be aware of the patient's comfort with this. That's going to be the biggest portion of, can you safely manipulate it? Because I'm not looking to like free up the joints, and I'm just looking to get them mobile, get the segments mobile that are not mobile. So have you seen that? Have you adjusted a fusion?
Yeah, I've adjusted the fusion, and
Sorry, let me correct that. Not adjusting a fusion, but adjusting around a fusion. Sorry.
right. And I've adjusted a patient with a cervical fusion. I'd probably say multiple times,
Yeah.
with no problem. I think the biggest problem is being able to identify if somebody has an actual unstable segment, because you can easily adjust that and then create pain in the cervical spine,
Yep.
and just are not too sure. So my experience with it was, we would adjust the spine and it would create pain afterwards, and then it would kind of click back, and it was just odd, and it would just click back. It would be painful, click back, painful. It happened twice, and that was it, and I was just done with it. And I was like, all right, we're just going to get an x-ray here. So I order the x-ray, and then I order a flexion extension view, and there was a slight spondylolisthesis there. I adjusted it, and I immediately, honestly, now that we talk about that again, I'm just like, that's one that I would like to have back a little bit.
Yeah.
But afterwards, it was just more so of like, oh man, like if a spondylo would react to this, and take it fine, I'm not too afraid of it. But it's more so of, don't be afraid to listen to your gut. If you, like, that second adjustment just didn't sit right with me, and I knew that there was something odd about it that I need to kind of look deeper into, and I'm glad I did, because I ended up finding something that could have ended badly if we didn't continue to investigate it.
Yeah, and it leads to a really increased success, like a higher likelihood of success when you took a step back and you're like, yeah, that wasn't right, that didn't feel right. Like
Right.
a lot of my patients, like, I will do so actually, let me ask you this. Like, if you go to, one of the most common things I hear with chiropractors is like, if it doesn't pop, some chiropractors will be like, oh, I didn't get it to go, and they'll hit you harder.
Right. Yep.
That scares the crap out of me. But other chiropractors will be like, oh no, it moved. Trust me,
Right.
it moved.
Yep.
And I'm like, no, I don't think so. And I not that it has to pop every time, because it doesn't. But I think you have to be really careful, especially when you're adjusting someone's neck, when you call them like, oh yeah, that moved. But guess what? Like, there's nothing wrong with going, yeah, I did an HVLA, which is, a high velocity, low amplitude adjustment, like aggressive move, and it didn't pop. There's nothing wrong with taking a step back and going, ooh, man, that was like hitting a rock wall. I need to go and do more mobilization. I need to spend more time mobilizing at the end range, and that's probably going to be the highest likelihood, because guess what? If it doesn't cavitate, you probably didn't create a ton of movement in that joint. Most joints that haven't moved for a long period of time tend to cavitate.
Right. And also too, are you applying the right amount of tension there, of actual getting that joint to end feel before you start thrusting on it? I think there's a lot of technique issues that happen out there that can easily be addressed before you start worrying about And is this going to cause this person a stroke?
And that changes so drastically from patient to patient. Like I've had some patients where I have laterally flexed their neck so far to lock out their cervical spine, and it
Right.
makes you wonder, like maybe it makes you wonder because you're like, well, maybe it's not that, stuck. Maybe the motion's not that, you know what I
Right.
mean?
Yep.
And you're like, oh, if I'm really taking it that far and I'm thrusting through it, well, that seems like full range of motion, isn't it? But
Right.
the restricted motion could be rotation, you know what I mean? Like,
hmm
and that's the key. That's the beauty of chiropractic is it's not necessarily the part four boards where it's vectors, line of drive,
Right.
the
Right.
perfect key.
Right.
Like literally sometimes you just feel where it's stuck and you just push it that direction. Like
hmm
as uh, unscientific as that sounds, that is the reality. But that's the beauty of chiropractors because we are so trained in manipulation that we're not hell bent on this is the setup, this is what you do, this is it. And that's why patients get hurt when I hear a physical therapist adjusting people or a massage therapist, or apparently in Arizona, there's myopractors who are unlicensed who whack on
Solid.
people that have no training because that's the difference. Like the difference is getting the thousands of patients in your hands and knowing what direction really you want to push it. You want to put that joint. That's the beauty of chiropractic.
Right. And not to veer too far off, when it comes to actual adjusting patients, especially in the cervical spine, just take your time and explain to them what's happening. You don't need to get into the gritty details of coupled movements and stuff like that, but just say like, hey, this is what I'm trying to achieve here. These are where I'm going to place my hands, and set them up. Gain that tension because the tension is the for I think in my opinion the worst part for the patients is the setup.
Yeah.
They're like, oh, what's about to happen? What's about to
The
happen?
loading. Yeah.
Yeah, and then once you load it and you deliver literally just like a slight push, it's usually very underwhelming, and that's what I typically get. The patient is like, "You made me so nervous by your explanation, and it wasn't anything." And I'm like, "Good, because that's what I want it to be. I want it to be this big buildup and this huge letdown, because it the end of the day, I'm just trying to get the joint to move. I'm not trying to rock your world. Like I'm not trying to have you see stars. That's not what I'm trying to get you to do. I really just want you to say, all right, I understand what a good adjustment is, and a good adjustment is one that applies enough force to achieve joint motion and doesn't get 15 cavitations. That's all I'm trying to achieve at that point.
So let's talk about this. So this is where I wanted to take it because this is awesome. So I'm going to tell anyone listening to this, take a second, go on YouTube, look up the ring dinger adjustment, and just watch it. Just watch the dude yelling ring dinger and yanking on people's heads. I'll let you
Yep.
go. So all right, here's the thing. If you've watched those videos and you've ever seen this, guy straps someone to the table, claims that their patellar tendon has poor reflex, straps them in, whatever, puts a towel around their neck, and literally yanks on their head with 100+ pounds of pressure. Okay? This is my absolute nightmare. This scares the crap out of me. Okay? So this is where we talk about, like Derek just said, I'm not trying to adjust everything. Like I'm not trying to go and wail on everything. Now, if I adjust your neck and there's multiple cavitations, that's not surprising to me. That doesn't surprise me, and that doesn't mean that I wasn't specific. But you watch those adjustments, you yank it on their head, they're like, oh man, that popped all the way down into my toes. Like, oh gosh, that is scary. So Derek, let me ask you this. What are your thoughts on the ring dinger and
Yeah. Um,
implementation?
I'm not going to lie. I've done it before.
No, come on, have you
Yeah,
really?
absolutely.
All
No,
right.
absolutely. And it's a matter of the same. It's the concept that I have with basically any other manual therapy. If you don't understand it, just dive into it. If it's interesting to you, just dive into it. Figure out what's going on. And he locks the pelvis down, and it's just a long axis traction of basically it's really just a long axis traction of your occiput.
Yeah,
I mean,
yeah, yeah.
it's all really you have to imagine you can't really develop such a far reach through just like traction. So when they're feeling, oh, I felt it all the way down to my toes, what they're actually feeling is just that nerve tension. You're just creating nerve tension through that. And for an adherent nerve root, you're lighting that person up. So stenosis, probably lighting them up. So it's not for everybody. And I'd probably say it's not for most. But I just don't think that it's a long axis traction really has much use. Maybe if you want to make a argument that the person plays football and a lot of contact and a lot of compressive forces, maybe. But I just had to see how it felt. So I did it to somebody, they did it to me. We decided that it sucked, or the way that we did it sucked, so we weren't going to do it. But it was more so just like, all right, let's just experiment with this. If it felt good, then let's just keep doing it to each other for maybe a week or two. And if it still feels good, then if a case walks in where we're just like, we're comfortable with the patient's comfortable with us, and we think that it might help them, sure, we can pull that out of our back pocket. But do not watch something on YouTube, apply it to a patient, unless you're willing to apply it to yourself.
So let me ask you this. So what about the philosophy around the cervical spine only taking, you shouldn't apply more than 30 pounds of traction pressure to the cervical spine, right? Because that's kind of our guidelines that we follow with like decompression tables, things like that.
Right.
You usually shouldn't exceed that. Do you run a risk with a move like that? Do you run a risk of damaging the soft tissue in the area?
I don't think so, because if you look at a lot of those studies, they were isolated traction.
Okay.
So everything else was really just strapped in, and then they applied the traction. When you watch those videos, even though he puts the bolsters around the iliac crest,
Mm-hmm.
there is still some wiggle room for that force.
Yeah, because you see him jump.
Exactly right. So there's going to be some dissipation of force. So it's hard to kind of gauge, okay, how much force is he pulling into it, and then how much force can the body actually withstand. Obviously, I think if you start to take in contraindications, this person has a neck spasm, this person has some type of instability within their cervical spine. Take all that into account, obviously do that. But I just don't think if you took a perfectly normal, happy, healthy 35-year-old male with no issues, I don't think if you know how to deliver that adjustment, I don't think you're doing any damage to them.
Okay.
I think the likelihood of you doing damage is very, very low, especially that doc who's giving out millions of ring dingers. He probably has a sign like McDonald's, 100 billion happy customers with dingers, and I guarantee he probably executes it extremely well. He gives it to everybody, so he's going to be pretty damn good at it. But once again, as we talked about with the manual therapy podcast, are there better options? How far is the ring dinger in my manual therapy toolbox? It's pretty far down there.
Yeah, it's
pretty far down there.
It is buried.
And it's just a matter, I think, of if we are going to say that, and it's kind of it's a weird dichotomy there too. Is if we're going to say that manual therapy is safe, where does that spectrum end? Is the ring dinger safe? And if so, why not? Because if we're saying that the ring dinger is not safe because he can impose an external amount of force too much for the cervical spine, then can we not make that same case for just a normal cervical adjustment? It's kind of a slippery slope at that point. I just think it's more so if we just stick with do your intake, do your history, rule out red flags, and then for the most part, conservative is always the best way to go, and don't go for the blast them right away.
Yeah, we're not
Just
hitting home runs on the first visits. Let's
right,
just say that.
exactly.
We just want to honestly like we just want to get on base. Like
Right. Yeah, that's it. Right. You want to get a little bit of movement and reduce secondary effects to the patient.
yep.
And secondary effects can be anywhere, but I tell my patients, it can be anywhere from soreness. Some patients might report a little bit of lightheadedness afterwards, and or some patients, when it's a pretty rough adjustment, might have headaches too. And that's when you have to start to really think about, man, did I really go after the suboccipital muscles the way I needed to before I delivered that adjustment?
Well, that's
Because
okay.
because
So,
sometimes you just didn't do the soft tissue that you needed to do.
man, and you just knocked it out of the park there. All right, so before we end here, I want to talk about this because when it comes to treating the cervical spine and it comes to treating headaches, if you don't have a good protocol for treating the suboccipitals, and I don't care if it's ART, NMR, whatever, if you don't have a good movement-based stretching treatment of the suboccipitals, you're missing the boat because like uh, I do a couple of occiput adjustments because I think that if it's needed, it is extremely beneficial. I've seen a lot of really great benefits with it in my office, and the greatest thing I've been able to do is treat the suboccipitals pre-adjustment, pre-occiput adjustment, and my goodness, does it make life so much easier for me and so much easier for the patient. That suboccipital care is one of the most important things I think I do when it comes to neck and headache treatment. I don't know about you, Derek, but it's important.
Right, and I think honestly I 100% agree that soft tissue, especially when applied to the correct areas, can make a huge difference in patient comfort during the setups and patient comfort after the adjustment.
Yeah, so here's the thing. Today, there's actually a really pretty cool topic to talk about a specific adjusting, because as sports chiropractors, we usually jump to like soft tissue manual therapies, assessments, things like that. And it's really nice to kind of get to our roots of chiropractic and talk about adjusting and how we implement adjusting, because I'll tell you my theory around adjusting, or my philosophy, I guess is what I want to say, has completely changed from being in school, being in clinic, being in practice for longer. Like, it changes, but it's so cool to be able to get down and like talk about why I do what I do. And if you're someone who you're hesitant about adjusting or adjusting the neck or whatever, figure out why you do what you do. Like, talk it through to yourself, talk it through with someone else, and you'll find that great passion for manipulation. Like, it's there, it works, it's awesome, it's a great tool. Like always, guys, we love hearing from you. Send us messages, hit us up on Facebook, Instagram, like us and follow us. It's always great talking to you guys, and we'll talk to you next time.